Okay, thank you, moderator. Thank you, chair. Good morning, ladies and gentlemen. I'm Junyu from Peking University Third Hospital. I'm really glad to be here for this oral presentation and as the representative of my mentors of my team. And my topic is selection of the proximal fusion level in OVCF kyphosis patients, the guidance of the Hounsfield Unit. There's nothing to disclosure. So the treatment of OVCF kyphosis is particularly important in the aging society. But how to select the UMV is a really good question, and the high postoperative mechanical complications are of concern to our spine surgeons. So by the literature review, we focus on the HU value. Firstly, HU value can reflect the BMD and biomechanical stress state of the vertebrae body. And secondly, using the chronal HU values to determine the chronal reverse vertebrae can guide the selection of UMV in DLS patients. So our question is, can HU value be used in sagittal alignment to identify biological nature of the vertebral bodies for guiding the UMV selection in OVCF patients? So we conducted this study, retrospectively enrolled 70 patients and asked a minimum follow-up of 2 years. And we collect some data like baseline information, the surgical data, and some imaging parameters, especially the HU values and the follow-up complications, PJK and adjacent segment disease degeneration. So there are two key concepts. The upper maximal vertebrae is defined as the vertebral body above the compressed segment with HU value higher than the proximal vertebral body of the fracture segment. And the upper central reverse vertebrae is defined as the first vertebral body in the sagittal alignment that has a CT value distribution opposite to the proximal vertebral body of the fracture segment. So from the baseline information, we can see that patients have advanced age and osteoporosis. And from the central parameters, we can see people have good recovery after surgery. And from the distribution, we can see that most UMV and URSV are located at CV +2 or CV +3. So from this chart, we can see that when UMV is located at or above the UMV, the incidence of the PJK or ASD is significantly reduced. Here are some examples. UMV T9, fusion to T9, no PJK. And UMV T10, fusion to T11, there's PJK. And UMV T8, and fused to T9, there's ASD. And we found 55 patients show the presence of the USRV. And when UMV is located at or above the USRV, the incidence of ASD is significantly reduced. So USRV T10, fusion to T11, there's ASD. So that's all for my study. So HU plays an important role in determining the UMV in patients with OVCF kyphosis. It could accurately reflect the BMD, and especially the concilium booms, and it could help with evaluate the biomechanical natures of the vertebral body. So from the previous study, low HU value of UMV have correlations with the ASD and UMV. So how to find the most suitable UMV in OVCF patients? So we think placing the UMV on UMV can effectively reduce the stress concentration, stabilize the fusion segment, and reduce the occurrence of the PJK and ASD. And also it can reduce the concentration in the adjacent unfused segment, slow down the vertebrae, cartilage, end plate lesions, and the intervertebrae disc degeneration. So according to the Wolff's law, the HU value can reflect the changes in stress on the vertebral body. The distribution of the HU value in the opposite direction of the adjacent vertebral body may also reflect the USRV may be a stress concentration zone. So as the midpoint of the shear force, we think USRV should be fixed. And also, our study have some limitations. It's a retrospective study. So in the future, maybe we want to conduct biomechanical tests and better control for the confounding factors. Maybe that could yield a better conclusion. So thank you very much, and welcome any discussion. And thank you, my mentor and my team.